as we get onto the formal part of the workshop, we'll remove the slides so that actually we can have a little bit more interaction, see people. Just a couple of housekeeping issues. This workshop is being recorded. You'll see at the top of your screen an indication telling you it's going to be recorded. If you are unhappy about being recorded, then I'm more than happy for you to step away, and that nothing will be inferred by that. But by the very nature of staying online, you are giving your consent for the meeting to be recorded. Clearly, the transcript and the record will be a matter of public record and accessible if a Health Select Committee ask, or indeed your members ask. So wanted to be an interactive session, but the first thing I really want to say is a huge thank you to all your members, all the extraordinary individuals that have made significant contributions through the recent peak pandemic period. Yes, I'm going to ask for continued commitment. Yes, I'm going to ask for a degree of continued patience as we progress through to the transition into recovery. And your members' part of our national response to the pandemic, and it is still a significant risk that the country bears, is vitally important. But clearly I've seen that we've had unstinting response, as I said, and I know that we've had dental teams across England providing that urgent telephone advice. I'm conscious of the extraordinary endeavours of those that have deployed into the urgent dental care centres, providing care both clinically and administratively. I'm conscious that we've had people on the front line who have deployed into the acute care settings. Some extraordinary work by some foundation trainees, both from the therapy side, I'm aware, and the young dentists. We've had people volunteering to help out on NHS 111 and the dental casualty line there. We've also been acutely aware of the individuals that have been volunteering in their local communities, supporting care homes, providing transport, delivering food packages, and just being brilliant citizens, but citizens that have brought their care potential and their emotional intelligence to bear in what is a very difficult time. I'm also aware that like me, you share people close to you that have suffered from COVID and the stress, strain, and as often as possible, the delight when people come out the other end and are able to restart life. I'm also conscious that for many, and in fact, you know, the 35,000 toll that COVID-19 has wrought on our society has made so many changes for families that I just can't reconcile and put into words. But I'm sure you, like me, send out your thoughts, your sympathies and your empathy. We're not out of COVID. I've heard people talking about a post-COVID environment. We're not out of COVID. We've got a long way to go. And we will be working with the authorities, understanding the population risk, the transmission risk, to be able to recommence and resume our role as dental care professionals and delivering safe and effective care in a safe and effective environment. I don't need to remind you that we asked people to step down from practice-based face-to-face care in March. I never thought as Chief Dental Officer I was ever going to ask the profession to stop providing care in the traditional way that we do. However, I've been humbled by the efforts of individuals to think about the innovation, the remote consultations that are going on, and the support. We're not out of the woods, and we need to think about how we are going to restart, and part of the conversations we've been having across a variety of groups over the last months, whether it's been written submissions, working with PHE, face-to-face conversations, workshops very similar to this, in understanding what are the challenges. everybody understood the rationale for the temporary suspension, and I absolutely understand why they're trying to understand now the rationale for what seems to be a continued suspension. And the continued suspension is to do with the ongoing transmission risk. So we still have a prevalence of COVID-19 in society, and the work out of Oxford shows us that there is 1 in every 370 people wandering out there with COVID, and we've got to think about how that works in the transmission risk for our patients, the public, and our workforce. And there has been significant discussion and academic papers on the risk to those in the dental environment. And the piece of work that came out of America, and many of you have seen it, the bubble chart on March the 15th, which had dental professionals sitting right at the top at the risk area of workforce environment and the transmission risk, with, I think, dentists sitting at about number 6. But you won't be surprised that dental hygienists and dental nurses sitting in that top 5 in terms of risk. So we have an onus of professional responsibility to our own workforce, and I know that you're acutely aware of that and are providing that advice. So we're now looking at working, as I say, with PHE to advise on the safe, effective resumption of dental care. There are a number of questions, and I'm going to go through those today just to talk through give you a bit of context of where we are, and then I'll open the floor to be able to respond to the questions that you have raised on behalf of your members. And we've assembled a group of expertise from the different areas, from the GDC to local dental network chairs, to FGDP UK, to Public Health England. Eric, I'm hoping, will be able to join us. He and I have literally just come off another series of conversations in developing the case for the Secretary of State, Department of Health, CMO, and the executive board here in how we safely and effectively resume dental care over the summer period, in line with all the other things that are going on. So I say, current trends, we're looking to start opening, but we can't just open up tomorrow. We need to prepare. So we might have been able to switch the lights off at an immediate notice because of risk, but we need to be able to prepare safely and effectively. So what I'm going to do is just go through some context setting slides with you. And then open the floor, so we've got an understanding. So we'll go to the next slide, please. Everybody's been asking us for a timetable. COVID didn't give us a timetable. COVID doesn't give us a timetable, but we can monitor conditions. And just as we use clinical judgment and we look at risk and we balance risk in the clinical environment to do what is best for the patient, we are balancing risk at a population level against the public health need and the oral health need of our patients. So working across the broader NHS recovery plan and the input that we've had in from a variety of agencies, you won't be surprised that there is both ambition and opportunity now with the reduction in the transmission risk. We're still in a sustained transmission risk, but it is lower than it was. You've all seen the R number reduce. We have the ability to safely and effectively move from what has been an extraordinary endeavour of 550 urgent dental care hubs across England providing care, as we then move into an ability to be able to expand access to all practices. That would be the ambition, that we were able to open all primary care dental practices to do what they've all been asking to do, which is to see their own patients, to do urgent dental care. Clearly there is an aerosol generating risk there, and we would like to be able to support practices making that transition. And I think there would be an expectation that we would only be looking at non-aerosol generating procedures at that initial commencement. We would still maintain the urgent dental care network to be able to support the provision of aerosol generating procedures, noting that there's still a desire because of risk to limit that. It would then, as further improvement in the transmission risk, we see other public health restrictions change. We'd be then looking at being able to support practices to expand their urgent dental care provision and think about the limited range of routine preventive procedures that we should be doing. And then we all aspire to full operating capability. But I think, as I've mentioned in my opinion article in the BDJ, pace, proximity, protection, preparation, and equity of access mean that there are a number of factors that mean that we won't be working at the pace we were before. So I'm, like you, a focus on full operating capability, but we recognise that will be at reduced capacity because of the social distancing and the patient flow, the restrictions on what happens after if you do undertake an AGP procedure, just working in PPE. And if it's going to be a hot summer, just working in PPE with all the ventilation issues is going to have an impact. So we just need a sort of a reality check with both NHS England, insurance companies, providers, practice owners about what is the art of the possible. And again, I think that will come out of a number of the discussions today in both answering your questions and setting the context. So next slide, please. As I said, the transition to recovery can't happen overnight. We've already produced, and it's waiting for publication because we want to give you the prompt to prepare. The prompt to prepare as a member of the practice team, a prompt to prepare in understanding where all the information is, be it about PPE, patient flow, how do you handle and do that clinical risk judgment. We know that just understanding the patient journey through a practice is going to create some infrastructure requirements, screens around reception, for example, actually working with your patients so they can understand, you can manage their expectations, thinking about how you might be able to work with those patients in terms of remote consultations, understanding what you might be able to purchase. And we understand that there are still issues with PPE, and we have Edmund Profit from the British Dental Industry Association, who's explaining to us the PPE flow, and if we are going to need to do things differently. So if we are going to do AGP and the requirement for rubber dam is one of the risk management issues, actually getting people used to remembering how they learnt to put rubber dam on, and I'm sure they all do for their endodontic procedures, but we're looking at it in terms of some of the other routine procedures. Thinking about how your staff come into work, maybe you're going to have to create rotas, and that's going to again have an impact on flow. We understand that there's also going to be a different approach to how you think about those different treatment modalities. And I know that everybody is well acquainted with the minimally invasive oral care approach. And again, I've mentioned that in my BDJ opinion article today. But that requires a broader understanding of everybody in the team and how they contribute to that. And I think as we move into that era, it absolutely highlights how it is a multidisciplinary team approach, how we do the prevention, the stabilisation, the restoration of function in this new world era. We'd like to be able to provide not just the sort of list of how to do it, but actually the signposts to those organisations like SDCEP, like FGDP UK, and some of the international guidance that is relevant. It is not all relevant, but is relevant to our environment. So that work's been going on, and again, waiting to publish. We, as you know, have to work through a number of gateway processes in both NHS England and the Department of Health. Many people having to sign off because there are many complex elements to the work that we are going to undertake and the risk management. So the work's been done, it's just waiting for that press to publish. But that doesn't mean that any of the good ideas that we're picking up today can't be added in as right, that needs to change, that's an amendment. And as we've done today, all our SOPs contain a sort of feedback section at the back, which says actually this could be written in a better way, this is a piece of evidence you might not have thought about, this has become, and we have got evidence building every day, so our documents are correct at the time of publication, but we welcome all the feedback in terms of readability, even grammar checking, but more importantly the evidence that enables us as a profession to do the best for our patients. Next slide, please. A little bit of a delay. Okay. So the prompt to prepare, which we would aim to get out in the very near future, is going to talk about the patient journey, because it's the patient that sits at the heart of what we do, and everybody has a role in supporting that patient journey. So just a sort of an idea, and I'm not going to go through that in detail today, but that is something to sort of whet your appetite for. I'll go into the next slide, please. I think the thing that's probably going to interest most people here is about the clinical guidance, and we've been working across the Faculty of Dental Surgery, bringing the specialist societies, the expertise and the evidence. We're working with the 4 CDOs across all 4 nations. We're working internationally with our colleagues in FDI, and interesting this morning, Tim Ricks, the CDO in America, has offered us some input. They welcomed our SOP, which we produced on the 28th of February, which is that one at the beginning of the broader the broader containment phase in advising practice how to work safely, and it's paid dividends because of the extraordinary exchange of information, the use of the evidence base, and I again take my hat off to DCP in what they've done recently for us, responding so quickly to our commission for the comparator across the international. But non-AGP is going to predominate for a variety of good reasons. That doesn't mean that we will not be doing care well. It means that we will be doing care differently, but we are looking at good health outcomes for our patients, and that is going to mean, again, a change in approach, but it's not a new approach. It's all evidence-based. It's been out there before, and many of you will be aware of the work that Avi Banerjee has been at the helm in terms of minimally invasive oral care, and I take you back to the work of Jimmy Steele and the whole approach, the multidisciplinary team, and the work that needs to go forward. So coming out of COVID, I would sense that we have a real opportunity to realise the legacy that Jimmy Steele left us in the future of oral health care and the multidisciplinary team, and for our champions of minimally invasive oral care, Avi Banerjee, continuing to support us and making this accessible with the support of HEE, the Dental Schools Council, and indeed yourselves. Next slide, please. As I said, we've got to understand where we sit at the moment, and I'm often asked, well, if they're doing this in Denmark, if they're doing this in Norway, if they're doing this in New Zealand, why aren't we? Well, there is a difference in terms of where all the countries sit in terms of their experience and the transmission rate. And the work coming out of Oxford and the Office of National Statistics, I put their detail there in terms of the risk that we sit. And I've used the phrase at the beginning, we're currently talking about a prevalence level of 1 in every 370 people carrying the virus. We don't currently have that mass testing, and I'm sure you're following the news as well as I am, in terms of how testing would allow us to be able to safely and effectively resume care for our patients. We now need to think about, there is an ambition for a vaccine, but that's still some way off. So how would we, with the advent of testing, be able to support our practices? If we haven't got the testing, how do we support our practices in safely and effectively triaging patients? And again, I see the role of the dental care professionals at the forefront in doing that important piece of work. A little bit more context before I draw this to a close in terms of setting the context. The next slide, I think, is quite telling. When you can see where we sit compared to the average number of new cases, yes, we are sitting in a downward trend for the time being, but you will have read in the newspapers and heard the concerns about the potential for a second peak. So whatever we do, we need to be able to not just step forward, but we need to be able to monitor, and we need to think about if we have to take a step back, we do. So this is not a one-way journey at the moment. But more importantly, I draw your attention to the fact that we are sitting in a very different environment to Canada, Germany, Spain, France and Belgium. And we look at what they're doing and the evidence that's coming out of there in terms of managing risk. And you will see that in terms of the urgent only care, moving to the non-AGP, and at the point in terms of average new cases where people then move to AGP. And it's interesting that in New Zealand, they waited for three days of no new cases before they were able to sort of lift the majority of their restrictions. Each time you lift a restriction in terms of public health measures, you do risk the R number, and it's interesting in London at the moment the R number is sitting around about 0.4, but interestingly up in the northwest and northeast, we're looking at an R number that is varying between 0.7, 0.8, and in one or two places closer to 1 than we would have desired. So, we whilst we have a national ambition, we also need to understand there are some regional differences. So all these factors come together to affect how we move forward, more importantly, when we move forward, and the risk management that we need to put in there, understanding that it is not just about PPE. PPE is one element of risk management. It's an important element, and its availability has an impact on the safety of our workforce, the safety of our patients, and the safety of our reputation as, again, effective providers of care in what is an unprecedented environment. We've all had to make difficult decisions, and the onus of responsibility of some of those difficult decisions absolutely sits with me. I absolutely get that a number of individuals are finding it uncomfortable, and they look for areas to vent. I again accept that as the responsibility of this role. It goes with the territory, I suppose. So just to bring you back, and I did see Fiona smile at our Mark Twain quote at the beginning. I am aware that on, I think it was not yesterday afternoon, the afternoon before, there was some Twitter conversation, and again, a series of assertions of people that think they have evidence. And at that time, it was they believe they had evidence of my resignation. Ladies and gentlemen, nothing could be further from the truth. We have a commitment, and I have a personal commitment, to supporting and leading this profession to where it needs to be, delivering safe, effective care for our patients, leading it through the transition to what I am hoping will be a new opportunity for oral healthcare, because we can learn from COVID. We can adapt. We are agile. We are robust individuals. And I do that with you. And it's a delight, again, to have this session today to work with you and to take your feedback. I don't have all the answers, but I know that we have, as a network, opportunities to go and find those answers, hence reaching out again today. It has been a busy period, I don't deny that, and there's a lot of stuff coming in. We have our peaks of activity, and your understanding through this has been admirable, and I'm humbled by those of you who have sent me some extraordinary messages, personal messages of support, confirming the intent, and those resonate daily against the background of some of the other clatter. So thank you very much for that. And you know I remain committed to patient care, patient oral health care, and the dental profession. So enough chatter from me. What I'm going to now is set the context, and we're going to open up the discussion. We will at the end of this come to a slide which I'm just going to give you a little heads up on now. In our work with the FGDP, BDA, and a number of other organisations, we had pulled together a form of words to talk about the consensus about understanding where we are and moving forward. And I would hope that maybe at the end of this, you may wish to consider joining those that have already indicated their desire to be able to say, this is us as a profession, this is what we wish to do for our patients, this is how we work together as one. So again, not asking for any immediate response, so we'll send an email round at the end for you to consider. That would be absolutely amazing. So we've got obviously the chat box going, and we will commence. I know there's a number of people want to say things, but at this point, with the exceptions of everybody else, Debbie has got her hand up. So Debbie, I know we're going to move into the questions. I think it's a comment you'd like to make. So Debbie, if you'd like to take the floor. Debbie McGovern? Oh, you need to unmute herself. You may be on mute still, Debbie. Okay, right, Debbie. We'll sort out that technical detail later. But I've noted that you wanted to speak. So, and I'm sure Ian, after yesterday's slow transmission from North Devon, will be able to sympathise with that, I'm sure. So I'm going to move on back to the agenda. So we'll flip back to the agenda so you can see the sort of questions and the areas, and there were a number of issues that I know individuals wanted to bring up. So I'm just going to ask. Work our way through. Okay, so there were some questions that came in about policy and guidance, and I'm going to hand over to Hema, who's got the list of questions, unless we want to take them particularly from any of the areas. I'm looking at you, Hema. Debbie, have you managed to sort out your technical issue yet? Fiona, just to let you know, the BDJ paper, it's in the BDJ. It's an opinion piece. I've got Martin online. I don't know whether Martin would. Oh no, he said he's left the conversation. So it is it went to print, and it's today's issue, the 22nd. So at the moment, I have to say it's sitting with the BDJ. I think it's available online. Does that help? I can't hear you. You're on mute too, Fiona.
I think it's just to say that I'm not sure that we can access that. We'll check with Martin though.
Okay, thanks very much. I'm sure Martin will make an exception on this occasion. Right. Okay. So some of the policy questions that came through. Does anyone want to fire off through? I'm just
social distancing be observed in dental.
So there's a I think it's come through from Pam. So it's talking about social distancing be observed in dental practices. That is a piece of work that, again, on the prompt to prepare. In the same way that the social distancing advice goes into the primary medical care, the social distancing across the whole of the healthcare sectors, that is an issue that we will be covering in the SOP, so the standard operating procedure. It is an extraordinarily good video that's been produced by Yorks and Humber and HEE, available on YouTube, which shows how they were doing the social distancing in terms of the patient care, the patient pathway, a patient literally coming from their car via text into the practice, and minimising the contact. That's all pretty much par for the course that's been working through the UDCs, and we've learnt a lot from the UDCs, which has gone again into the SOP that we published in time. In the prompt to prepare document that we would like to be able to publish in the next few days, I'm going to love it to say it was in the next few hours. Again, all that advice and the hyperlinks to that very good video are there. So social distancing, again, because we obviously don't have the plans for every practice, every 10,500 practices, then absolutely, I think, to quote Dominic Raab, pragmatic common sense about how you create that social distancing, be it plastic screens at reception, staggering arrival of your staff, thinking about your staff rotas, thinking about how you do your appointment scheduling, making sure that you don't have large numbers of patients, advising patients to come in a smaller number of groups, whether they have to have a guardian or a carer. So it's pretty much common sense in terms of the social distancing. That's, I think, pretty much covered. Pam, do you want to come back on that question and the overview I've given you there?
No, thank you. It's a question which we are very often asked, because of course a lot of dental nurses are concerned when they work in private practices. They're being told they're going to go back next week, whatever, and there are a number of concerns around that. One of which is social distancing, although there are quite a lot of others. But obviously, you've taken that into consideration. Yes,
and aware that a number of practices are thinking of going back. I would hope that practices would take into serious consideration the current prevalence, that they are absolutely assured that they have all the appropriate protection in place for their staff and and their themselves, as well as the public. It would not be my considered advice for practices to be going back until we have all the relevant public health England evaluated risk and an understanding that we are no longer in sustained transmission. Republic of Ireland moved to contained transmission. That is a different to where we are at the moment in sustained transmission. And ask again people to think very carefully about the public health requirements and the continuing rationale for the temporary suspension, which is advised.
Thank you. We had a question from the Orthodontic Technicians Association.
Okay, I'm looking here.
Restrictions shall be in place for
So we're talking about here restrictions to be in place regarding treatments able to be carried out in terms of dental, orthodontics, crown and bridge work. Now, clearly, areas where we have aerosol generating procedures carries with it significant risk. You have read the evidence as much as I do. Risk can be mitigated by, number one, minimising both the frequency and duration of AGP, but also with all the other measures in place. For the variety of reasons that we have at the moment, our considered assessment of the risk, both to the public, the patients and practitioners, is that AGP is something we would wish to continue concentrating in our urgent dental care centres, where the appropriate FFP3 masks, the appropriate gowns, the appropriate procedures are well rehearsed and understood, and the clinical judgment for those procedures is undertaken in consideration of those factors. Clearly, in order to undertake AGP at the moment, the wearing of an FFP3 mask, and I'm probably straying into some of our PHEs, requires a fit testing. There are a number of varieties of FFP3 masks, so just because you've been fit tested for one doesn't mean you're fit tested for all. There are changes in size. Your practice might be ordering one FFP3 mask, you might be fit tested, but because some of the shortages globally, your next stock of FFP3 masks might be different. Again, that requires another fit testing. So again, this is why opening is not quite straightforward as coming in and switching on the lights. There is a lot of preparation to be done, and I would sense that practices would need to be thinking about, say, a 5 to 10 day period of thinking about that preparation, making sure their staff are fully acquainted with the donning and the doffing of all the relevant FFP3 masks, the gowns and so forth, which is a way where we're focusing our efforts at the moment, still on the 550 places that we got. Now, Nick, am I thinking, Nick Barker, you wanted to come in and talk about that? Because I know over in the east of England, the UDCs have set a benchmark in excellence for the delivery of the UDC and the AGP work. So, Nick, I'll invite you in there. I think that's why you've got your hand up.
Yes, it was. Thanks, Sarah. Yeah, thanks for the kind words. I'm not sure about excellence, but that's for another conversation another day. What we're now, from our learning, because obviously we've opened for a while, we're now having conversations with our orthodontic colleagues, and particularly our orthodontic managed clinical network chair, to look at how we manage orthodontic urgencies. We know there are risks on that. Having had the conversation in the very recent past, I'm reliably informed that orthodontics can provide many of their procedures, particularly their urgencies, without generating aerosol generating procedures. So I think that's probably another piece of work looking forward. We haven't started it yet, but I'm quite happy to feedback how that develops through my orthodontic colleagues.
Okay, thanks very much. And I think, if I just say, there's a comment from Debbie about, are you surprised dental profession hasn't been decimated with COVID cases? And I think the issue here is that the big call to arms across all countries was to reduce footfall into the dental practices, which we've seen almost universally, and then to gradually return to resumption of services using the non-AGP approach, the alternative methodologies, but more importantly, again, the absolutely fantastic adherence to the use of PPE, our exceptional infection protection, protection and control that we're renowned for, and the public have no fears about our extraordinarily competent and confident IPC within our clinics. And again, that lies quite firmly with the amazing range of dental care practitioners and DCPs, who again take their from HTMO 105 to the in-clinic to the general good practice, best practice that we know that will be be back on the forefront of our clinics. But Nick, I'd say the lessons learned from the east of England are valuable, and again, many of those have gone into the SOP. At this point, Eric, I know that you've been producing the revision of the SOP, and I know you've got to leave us at 11:15. I don't want you leave without giving you the opportunity. Is there anything that you would like to add in about the next steps in terms of the UDC SOP as we broaden urgent dental care out to all practices to contribute to? Eric was there.
Thanks, Sarah. Yeah, I was, and I was talking away as I usually do, and nobody could hear me because I was on mute, which is a very common thing on this this platform, isn't it? However, yeah, thanks for that, Sarah. So myself and Alina have been working on effectively revising the current standard operating procedure for the urgent dental care centres to take account of if we are expanding out and enabling practices to do their own urgent care activity, although not AGP activity, then we're effectively extending the range of what is still an urgent care system at this point. And so we are reflecting the fact that practices will be engaged in that and making the changes to the current urgent dental care system SOP to support that. And that includes all the kind of things that you might expect, and some of the things that you have mentioned already, Sarah, in terms of how that will need to work. A lot of it potentially around commissioners and LDN chairs and LDNs and MCNs, or whoever is involved in the local systems, reviewing the current approach that they have, and, for example, their communications, their links with the directory of services at the sort of incoming end of patients, if you like, their triaging approach, and reflecting then how they need to change some of those things to support the fact that actually it wouldn't then be about having done some initial triage at practice, deciding to send somebody to an urgent dental care centre. In fact, they can pick that up in their own in their own practice if it is a non-AGP activity. I think we also recognise, and we discussed this with the group, the wider group of stakeholders that we were talking to yesterday, around the importance of clinical judgment in this, particularly in a practice where if you're doing both the remote stage, and there is still a requirement to have a remote stage to this in order to identify effectively the initial risk assessment of the patient, i.e. are they either someone who is exhibiting or a confirmed case of COVID or exhibiting the symptoms, or secondly, is it a person who is in one of the shielded categories, in which case some careful thought needs to be given about how one might address their needs, given that we are trying at all costs to keep them as isolated from the virus or potential virus contact as possible. So given that the practice would potentially be doing both the remote part and then subsequent non-AGP at this stage treatment, then the latter part of the triage aspect around remote prescribing and that sort of thing, clearly if people feel that actually it would be better to sort of eyeball what the clinical situation is, then of course that's perfectly acceptable. So there's a degree of flexibility around the boundary, if you like, between the triage phase and the face-to-face phase. So we're trying to build all those things in, taking the advice both yesterday and things that come from today, in order to make that as supportive as possible for the next phase.
Thanks very much there, Eric. So Fiona just asked, was there a work stream looking at how we go backwards smoothly? As I said, one of the whole points of having a graduated, phased approach so you can monitor and sustain. It may be that you can move through a multitude of phases quickly, should the risk allow you to. And that's, again, just as you think about patient care, you stabilize a patient, you have a treatment plan, you monitor that patient, and sometimes you can move them through certain pathways. This is exactly like that sort of treatment planning. And in this case, the patient is the population and the risk, and how are we monitoring that? And yes, sometimes as you go back, so exactly that. Why the reason for putting in a number of steps, which would say we might move through quite quickly, means that we can also move backwards if required. This is all about public health safety first, and then it's about the profession's safety. And I'm acutely aware, and I think I spoke to the team yesterday, that when I look at the registrant profile on the GDC, there is I think we've got it's 35% that provide a heritage and background of BAME. If I take that for England only, then it's 47.9%. And we know in terms of risk for healthcare workers, the prevalence of COVID, those that are actively in the frontline care, it's 6 times the prevalence that it is in a community base. We also know that an underlying health condition, age, gender, and ethnicity are all factors, and that, I'm sure you can think about the dental profession, and you can think about where the dental profession, again, for a variety of reasons, not just restricted to the unique close clinical proximity we have to our patients, working often less than 40 centimetres away from someone's oral cavity. We know that the COVID virus sits in the oral cavity and back of the nasal cavity, and of course where we're undertaking aerosol generating procedures. You start to build up the risk profile, and that's what we have to manage. So in terms of both transmission both ways, and also protecting our workforce. In terms of the SOPs are not exclusively written for NHS. They are standard operating procedures that bring together the evidence base for safe, effective care. And I would urge any provider of care, whether they are providing care to a patient that is funded by an NHS model, or is funded by an insurance model, or is funded out of the patient. The SOP is not written for the practice, it is written for patient care. And that's what it applies to. So I'm sort of disappointed that people think that might be, oh, well, it's only written for the NHS. No, they are there. They are evidence-based standard operating procedures. So I think we've got a question in from Debbie Worthington. I'm conscious that we might be going off the agenda, and I really do want to get onto PPE and antigen testing. So if you don't mind, I'm going to keep those to the end towards our AOB. We have and we're keeping account of all these questions, and they're being passed in front of me, so we're not going to lose them. But I think at this point it would be useful now, knowing Eric's got to disappear. We asked Public Health England, I think Sandra may be on leave, but Sally Weston-Price, I was told, was going to be joining us today. And I know that she was passed the questions on PPE and antigen testing. So I'm going to pass over the floor to give us a quick little update and answer some of those key questions. So I'm looking at HEMA. Have we checked that Sally Weston-Price or Sandra White is available?
Sent out the,
Have we had them click in this morning to say they're here?
no, they're not here.
So it would appear that communication has not worked effectively into that particular, and I can only apologise. We'll pick that up with, we'll pick up those questions and send them back to our Public Health England team. They are probably doing what, picking up on the pieces of work that we've just finished off with the Department of Health. So I think if you'll excuse their absence, it's probably because they're dealing with the Secretary of State CMO issue, which is related to our ambition to open dental centres as quickly as possible. So I'm hoping now, I'm looking at HEMA, I'm hoping we've got Sana on the line. And we'll move on to the training and the workforce piece, where I know, again, we have had a number of questions. Those questions have been passed to Sana and Donna. So I'm going to pass on there at 1 minute ahead of what you should have been. So I hope we haven't caught you on the hop, Donna or Sana.
I know, not at all. I don't believe Donna is with us. Just looking at the list.
Donna
Sue is with here.
But I'm here. Sue Ellis is representing Donna today.
So we have had a question about reassuring the profession, and in particular dental nurses who are responsible for infection control, prevention and control, that there'll be a well-structured training program. And that's absolutely what we're working with in terms of one of the work streams of returning to work is around resilience and is around training the workforce. So working across the work with HE and other stakeholders to make sure that we have a comprehensive range of training programs, both ones that can be accessed face-to-face and respect social distancing, but also for those who might not be able to access those face-to-face, to be able to access those through online forums. So absolutely, that's something that we are looking at and as we speak, and working also with the BDA to produce training programs, including training programs around rubber dam and rubber dam placement as well. So updating and the current workforce, as well as looking at training the new workforce.
I just reiterate what Sam has just said, and here in the Northwest, again, it's we work with NHSE and PHE on a daily. It's now moving to weekly, where we're looking now at providing everything that we've done with the urgent dental care sites. There's been training programs attached to that as part of their standing operating procedures and their service level agreements. And we're working now with them as they are moving into the dental recovery phase, delivering on the same pathway as what Sam has just mentioned.
And I think there's been a further question around, specifically around dental education, which obviously has impacted everyone, from undergraduate dental students to postgraduate programs, or for all the dental team members. And you know, it's a changing and evolving area. We don't have the answers, but we're all working together to try and get to some of those answers as soon as we can. Clearly, it has impacted on dental nursing because, as has been mentioned by in the question, that dental nursing is predominantly work-based learning. So that's definitely an area that, again, I'm aware that HE are currently looking at, and again with the work stream from the office of the CDO that's currently happening in terms of looking ahead and how we're going to prepare the workforce. That is also being considered, and will give absolutely will have prominence and will be highlighted.
Son, I just wondered if you'd comment, because we've had some extraordinary feedback on the DCPs that have been redeployed into a number of locations. I mean, I have been staggered by the extraordinary letters of commendation we've had from individuals who have taken on DCPs to work in some of the acute settings. Just talk about, I mean, the numbers that did volunteer has been extraordinary. Could you offer us a little bit of insight on that? Because you've adeptly handled what has been, I think, over 17,000 people.
Yeah,
volunteering.
I mean, overall, it's just been incredible that we have had so many volunteers. We have had, as you said, over 17,000 volunteers from the dental workforce, of which we have had, in terms of dental nurses, we've had about over 3,500 from dental nurses. over 1,000 from therapists and hygienists, and considerable numbers from dental technicians, from those in a managerial role, and from other roles as well. So it's been a huge response. We have also had really great feedback, not just about dental nurses and DCPs who worked in UDCs, but great examples have been in, for example, in Nightingale in London. We've had fantastic feedback from orthodontic therapists that have been working there, from hygienists and therapists. Just a good example from the top of my head, I know we've had one of our foundation therapists who supported the triaging of 111 in London, and she was, had such good feedback that the commission has actually come back and said, please, can we utilize her more? And it's just, the skills that they've demonstrated has been brilliant in both dental and non-dental care settings. And I think that's part of the discussions for the future about how the dental workforce have incredible skills that can actually be put and implemented in different formats, and how can we capture that and utilize that, and actually make the wider healthcare profession as well as the public aware of the skills that the dental profession have.
Thank you very much, Sarah. That's great. We're now going to move on to the sort of regulation area. I know John Milnes joined us today, and we've got Stefan from the GDC. And I am just hoping that the questions that were fielded have actually made their way to you, and you have seen them. There appears to have been some small some communication hiccup along the way with some of our individuals. We're trying to get PHE online now, but John, clearly CQC have been in the news recently. Any comments that you'd like to make? And then Stefan, I know that we issued what was called a letter of comfort, which was about supporting individuals that were utilising their scope of practice out with the sort of traditional clinical environment. So I think that might be something else to talk about. So John, over to you, if I may first.
Okay, can you hear me now? Great, thank you. Well, I think the prime aim of CQC as a regulator, as always, is that we're looking for people to be delivering care where they deliver it in a safe way. I think one of the questions earlier on about the standard operating procedure was asking whether that might be available for private practices or for NHS. Certainly, as far as the CQC is concerned, safe delivery of services applies whether it be NHS or whether it be private. It's the care of the patient that is paramount, and as Sarah has outlined in this instance, the route to recovery is very much one that's based around public health. So in terms of what CQC will do, we will be looking to others to provide the statement, standard operating procedures and the like. We know that the Faculty of General Dental Practice will be producing something soon, and we expect something to be produced, as Sarah said, by those who are advising her. So those are the things that we will be looking for as evidence of safe practice. It's clearly a fast moving process, and we're beginning to think about how infection prevention and control might need to change going forward as practices return to whatever the new normal might look like. But as always, the basic position of the CQC is that we're expecting providers to deliver care in a safe way.
Thanks very much. I'm just Stefan. Clearly, there's been not just the scope of practice, but I think that there have been a number of issues where dental care professionals are seeking advice, and they might feel that they are being pressured in some cases to undertake care where they may have concerns about safety, personal protection, public and patient protection. Perhaps some advice on that, and the role of the regulator would be quite useful for the group here. Thanks.
Yes, of course, Sarah. Thank you. Firstly, to echo John's point, as with CQC, GDC is a regulator of the profession of wherever dentistry happens, in whatever context, NHS or private. Our advice is not different in those in those different contexts. I think listening to this conversation and with Sarah's prompt, there are a few things it's probably worth running down. The first is that we've tried to be as clear as we possibly could right from the outset of this, that in extraordinary times, we recognise that people are having to take extraordinary decisions, and that some of what we would expect to do normally isn't possible or can't be done in the normal way. And we are not, as a regulator, sitting waiting to second guess well-grounded professional judgments. And in particular, we said very early on that the judgment about when it is appropriate both to give treatment and not to give treatment, either in general or of specific kinds, very much needs to reflect an assessment of the risk to the patient, obviously, but also to the treating professionals and indeed anybody else in the treatment environment. So where there are concerns, it is perfectly proper to hesitate, to ask the rigorous questions about whether everybody involved is in a safe state to give and to receive treatment, and to raise concerns, ideally within the practice environment where that may appear not to be the case. And that obviously links very closely with everything that was being said in the earlier part of the discussion about the conditions under which increasingly treatment can resume of a more normal, though far from normal, characteristic. Picking up some of what Sarah was saying around Sarah was saying about the roles of professionals outside the normal dental environment. Again, we've been clear that what matters is that people do what they are trained and competent to do. Clearly, within a normal dental scope of practice, roles have different skills and different attributes. People make different contributions to the overall support and treatment of patients. When dental professionals are working outside those normal environments, again, the basic principles help us all think this through. If you are asked to do something that is already within the scope of the skills that you have from your core professional background, that's absolutely fine. If you're asked to do something beyond those skills and have the support and training from the environment in which you are working, that too is fine. And again, we're not going to be looking to second guess issues where people are making sensible, grounded judgments in the circumstances in which they find themselves. I'd like to go back, if I may, also to the discussion about education, and particularly for dental nurses. Part of my team has been doing a lot of work with education providers since all this began, about ensuring, first of all, that those approaching the end of their training across the whole range of professions, we and the education providers can provide the transition in terms of quite basic things like providing the right assessments so that people can be, as it were, signed off as having completed their courses, which in turn sets the qualifications for entry to the register. I think it is true that early on, the bulk of that effort was focused on more traditional higher education based activities and the graduating cohort of BDS graduates in particular. But we have not lost sight of the whole range of education quality support, and we are working closely with all the qualification providers to make sure that the routes stay open as far as we can possibly make it and possibly support it. And one actually slightly unexpected data point, to me at least. I thought there was a real risk that the flow of new registrations, and obviously you'll appreciate that there's a very big summer peak for those who are emerging from higher education, but for those who are in more workplace-based vocational training environments, there's a reasonably predictable flow through the year of new qualifications and therefore new registrations. That number has not particularly dipped. So people are managing to come through the process, get the qualification, and get themselves lined up to join the register. And again, we're very glad to be able to support that. There was one specific question, I think, of those that were flagged in advance that we're probably best placed to respond to, which was the question about whether it's right for hygienists and therapists to work without support in a practice environment. And there is a line in our standards of practice that says that there must be appropriate support. Something does hang on the word appropriate there, and the supporting guidance, rather than the mandatory standard, does talk about the presence of a second person being important in a lot of contexts. I am told, and this goes before my direct knowledge of this, but I'm told that when those standards were being drafted, there was quite strong representation from hygienist and therapist communities at the time that working alone was actually something they thought was normal and reasonable practice and valued having the flexibility to do. I make no judgment on that. I merely leave that as an observation. I think what matters in this context, though, is that appropriateness is appropriate to the circumstances. And in current circumstances, particularly as we start to resume other forms of treatment, the need for there to be a second person present, particularly to support AGPs when that does become a more prevalent dimension of practice, I think the circumstances in which that second person will be absolutely critical may well be greater than they had been in a pre-COVID environment. But from the perspective of a practitioner who feels that they need that second person to deliver safe and effective care, then absolutely it is both their professional responsibility to ensure that they don't work if they don't think the safe environment is present, but also to signal very clearly to practice owners or others who they may be feeling are constraining their their abilities to work effectively. Excuse me. The standards do exist. They should be taken seriously. But as I say, with that slight fine-grained distinction between the core principle of appropriate support, which is mandatory, and ways in which that appropriate support is given, where there is inevitably and rightly an element of judgment. And I'm going to end, I think, by just saying something about a point which I know will be in all your minds because of the announcement we made earlier this week about the annual retention fee. I know that's a disappointing message and one that you had been hoping not to hear from us. I can't make that message a better one than was contained in the message that Bill Moyes sent to every registrant. What I can underline is that this was not a casual decision. It wasn't one the council reached without a lot of very careful deliberation. What I ultimately boiled down to is that GDC is an organisation that doesn't have a strong independent financial foundation. We operate on actually quite limited cash flow, and the risk of prevailing uncertainty because of the pandemic meant that council formed the view that they could not safely reduce the ARF at this stage without putting at risk our ability to continue our statutory legal obligations, which fundamentally are there to safeguard patients and the profession itself. As I say, I appreciate that's somewhat cold comfort, but as I say, this was not this is not an arbitrary or frivolous decision. It was one the council made with very proper consideration of the range of factors that pushed in both directions on that decision.
Thanks very much, Stefan. There are a number of, you mentioned ARFF, but there are a number of other financial terms and conditions of service issues that have been raised by the DCPs. As I've said before, unfortunately, it is not within the remit of the CDO England to be able to intervene within an individual's employment contract with their employer, and the very nature of the NHS contract for dental care with the practice is not one that I'm able to confidently comment on with respect to pension entitlements. So Pam, with respect to your questions about NHS practices, NHS pension scheme, I'm going to need to ask you to take that up directly. Well, I think there's two people you need to take that up directly. Number one, obviously, is the British Dental Association, who are the key negotiators in terms of contracting with NHS England, and also make the application into NHS England to talk to the central team on primary care contracts and commissioning. I'm sorry if that sounds a little dismissive, it's not meant to. I'm very interested in it, but I have neither the levers nor the gift to be able to make that happen for you. Clearly, if there is an articulate and compelling case that you want to throw past our team to have a look at, we would be interested in supporting how you put that case together. But the gift, as say, sits really with the employer, which of course in this case is not NHS England, it is the and Martin has just arrived back. So Martin has just arrived back into the lobby. I think we've accepted him in. It may be an opportunity just to consider picking up as we're progressing back to resumption of services, a conversation with Martin Woodrow and the BDA about how you shape that. But I'm clear. Now, John's got his hand raised. Did you want to come back in there on something, John?
Yes, I'd be grateful. Thank you. What I should have mentioned but didn't. For those that aren't aware of it, the CQC's updated our guidance for dentists on our website, and the chief inspector for primary care, which includes dentistry, Rosie Benwith and myself, we wrote to every dental provider earlier on this week. So the position of CQC should be clear, and within that position we do encourage providers to carefully consider the guidance that other bodies and other people, such as the Chief Dental Officer, Chief Medical Officer, and all those types of people, put forward for the profession to look at.
Thanks very much, John. There's a couple of other questions here. So one of the questions that's come in is about explaining the point at which AGB procedures could be undertaken. As I said at the beginning, COVID-19 doesn't give us a timeline. It's all conditions based. When the risk conditions are such that we can confidently say we are no longer in a sustained transmission environment, that will be the ability for us to be able to work with the profession to make the appropriate risk-based clinical judgments. And of course, for every patient that may vary depending on what the need is, hence the AGP that does take place in the urgent dental care hubs. A question was asked also about Germany. So Germany does use the urgent dental care hub system for patients that are suspected or confirmed as COVID-19. Because they have a different approach to testing and so forth, that allows them that a different approach. In our sustained transmission environment, the current direction is that every patient presents a risk. Therefore, every patient that walks through your door is a suspect or unconfirmed COVID-19 case. Hence, the use of the concentration into the 550 urgent dental care centres. And we wait for PHE guidance. And next week you'll be aware that SAGE will be releasing the new modelling, but we wait for PHE guidance to be able to confirm that we have moved from sustained transmission into contained transmission, and that is one of the factors amongst many other things, of which PPE availability is also a factor for practices, which leads me on to the other question about PPE. In terms of availability of PPE, again, that's a contract between the purchaser and the provider. There is clearly an NHS element of provision into acute care settings and support to care settings. The work we have undertaken with the British Dental Industry Association means that they are looking to be measured in their ability to provide PPE where it is going to meet the need and the needs of the patient and their urgent healthcare needs. Then thinking about the shift into the sort of routine preventative care for the high priority groups, and then thinking about how we expand onto the broader care, which is why I said we have this stepwise transition process that takes us from where we are today, which I know is not ideal for you, but it is ideal in terms of maintaining our contribution to public health safety. In terms of the other questions that come, the Dental Technologists Association, you asked many questions which are related to your particular environment. Most of those are covered in the policy issued by Public Health England generally for healthcare environments, and also under the Health and Safety Executive. We will provide you with the appropriate signposts to allow you to understand how those then will apply in your particular working environment. There was another question here about the communication out. So I think it's Debbie, you asked about communication and the use of the GDC website. Just to confirm that whenever we issue any information from our office, it goes out to every major stakeholder, including yourselves. You are on that stakeholder list. I am grateful to all of those stakeholders who then publish either the hyperlinks to where we put it on the NHS website, or indeed put it on their own websites and provide the signposts. So in terms of cascade to individual members, that's the responsibility of you, the representatives of your groups. And again, I'm very grateful for the diligence you undertake in cascading that information out. I'm not sure it is appropriate for the GDC to be utilising its GDPR covered address list to be sending out information in quite that way when they can post it on their website. Stefan, do you want to add anything in there about the use of the GDC? Because I think besides the GDC and the CQC, there are no other nationally held lists of individuals providing care or practices providing care, but both are governed by GDPR. So perhaps a comment from both GDC and CQC in how you cascade the information we pass on to you, and what the limitations are with respect to the further promulgation. Stefan first.
Yeah, you're absolutely right, Sarah. There clearly are GDPR issues around this, but we do have the only complete set of data about the full range of individual professionals, and that is an important asset for the community as a whole, not just for GDC in isolation. What we have chosen to do for the duration of the pandemic is be a bit more open about that than we have tended to be in the past, and we have offered our mailing list as a service to as a route for authoritative communication where there is clear value to the registrants in providing that. And we have done that both at national and subnational levels. So we have passed on communications, I think, from both the Scottish and Welsh CDOs, certainly from Tom Ferris. We have done so at the request of certain LDCs to the registrants across their local areas. And we are willing in principle to do that in other contexts too. There is there are some practical limits to what we can do, partly because once you start sending emails by the 100,000 at a time, there's a real cost involved in that. But the structure of the contract we have does give us a degree of headroom, which, as I say, we're prepared to use. So it's not appropriate to use that mailing list as a universal conduit for everything. We do provide a regular newsletter to registrants, and we have used that to share links. We are one of those organisations which has been doing its best to bring together links to advice from the various authoritative providers of guidance on our website. So I'm not giving an entirely straightforward answer, but if there is appetite and real need to reach individual registrants at the individual level, then we do have a route that makes that possible.
Thanks, Ray. John, a comment, and then I'm going to ask Andrea to come in. I know you've asked for an opportunity to speak. So, John, just to finalise that piece there for me,
yeah,
please.
really quickly, very, very similar to the GDC. We have a database of all dental providers in England, which is effectively a database of all dental practices, and similar to the GDC, we'll provide links to information from authoritative sources, and we'll continue to do that.
Thanks very much. Right, Andrea. Andrew, you may be on mute still. Okay, well, Andrew's finding out how she switches on mute. Deborah Worthington.
Yes, can you hear me?
We can, thank you. Good morning.
Good morning. I was responding to a comment earlier in the conversation about orthodontic emergencies. Salford Royal, where I work, have been providing urgent dental care for oral surgery and orthodontic emergencies for the whole of Greater Manchester, and it is something we're providing well by good triaging of patients. And for example, on Tuesday we saw 8 orthodontic emergencies, which went really well. It's about your timing of your patients into your waiting room and the specific procedure you provide for those patients. My other 2 points you were going to pick up, will we get feedback on the FFP3 versus FFP2 mask situation, and also antigen testing for colleagues who may find providing AGPs a little more appeasing if they have antigen testing?
So that's, as I said, unfortunately, Public Health England, we've been desperately trying to track them down this morning and been unable to. They are the individuals that are leading on that, and they are the authoritative guidance. In terms of testing, we are currently in conversation with the broader testing programme, because we recognise that there is benefit for workforce testing, dental workforce testing, but as you can imagine, with what is 33,000 dentists on the GDC register, in excess of 50,000 dental nurses, are hygienists and therapists, amounting to another 13,000. And when we take in all the broader other organisations that are registrants, you know, we're suddenly looking at a minimum of 120,000 individuals possibly needing to be tested fortnightly. That is not insurmountable, but it's something that needs to be factored into the broader piece, and it would probably be antibody testing as opposed to antigen testing, but then that is a broader piece. So the dental workforce are absolutely recognised as part of the primary care workforce, in terms of the broader piece, as well as those working in secondary care. So any of the individuals working in a secondary healthcare environment providing dental or oral care will be wrapped up in the whatever the procedure is for that particular trust. And for those working outside within primary care, we have made the case for all registrants, irrespective of whether they're providing care for, as I say, a privately independent or NHS funded patient. Patient safety is what is to be assured. So again, it's not about the dentist or the DCP, it is about patient safety. So that's a piece of work that's being taken forward in the broader programme. In terms of your questions, yes, we will take those, I've said before, back to PHE and the various experts for the various areas that are looking to be able to provide you with those answers based on the evidence available and the best practice and the protocols that are coming in from our experience. We've had a question about denture repairs, and it leads me on from you highlighting the piece of work that was being done in Salford for orthodontics, because that's not unique to Manchester. Each of the regions is clearly responsible for understanding what the needs of its patients are, and each of the regions then looks at what skill sets, capabilities they are able to bring into their urgent dental care network. The urgent dental care network is clearly more than just attending to what is being perhaps traditionally thought of. So I am again, Nick's probably got a couple of examples in terms of where we have thought differently about how we meet a patient's needs. And I know from Hertfordshire the other day, when there was an example of how denture repairs were done for some individuals in a care home, and the innovative way in which the team were able to circumvent what seemed to be some intransigence from groups of individuals saying, well, that doesn't constitute emergency care, where there is going to be clearly systemic effects for the patient. They were able to retrieve disinfected dentures. They were then able to carefully, in this case, make the appropriate repair, do the appropriate decontamination processes, and return successfully to that care home for those patients to be able to put those dentures in place. And consideration has also been taken when patients have been able to be moved to an urgent dental care centre, and those repairs have been done. And that's just an example of how local area teams, understanding who they've got at they call it arm's length, to be able to support the care. So, you know, we run, I mean, I often say that Wales is the size of Manchester, and what they've done in Wales reflects some of the innovative things that Colette brought out of Manchester and taken into Wales. Manchester's been very innovative. We've seen the Northwest and the Northeast, and I know you think I keep doing this to you, Nick. I'm not setting you up for failure here. You are, again, some of the extraordinary things, the domiciliary SOP that you've produced to be able to provide some support. Have you got any examples perhaps you'd like to bring to them about, again, perhaps on the denture repair piece and working with the dental technicians? That would be really useful. Yeah. Now, are those your dogs?
No.
They're mine.
I'm unfortunately clinical today, so if I've got dogs around, there's something very wrong. I don't think that will meet with cross-infection control procedures. So yeah, no, I think we have a number. I think the greatest learning we've got is joining across all of the professional bodies across the profession. So we're already we're sort of thinking ahead already. So we're trying to make this connection through orthodontic practices, as I said earlier, oral surgery practices, through technicians. And we're also looking, I was very much looking at the work going forward with prevention and trying to engage dental nurses, hygienists, therapists in the work going forward, so that we're starting to spread outwards from dental practices as well. And I think that's going to be a very important piece of how we'll manage that. But at the moment, I think it's that communication network that's key. So we've set up an oversight body, a governance body of senior clinicians who are able to then disseminate work out as they feel appropriate to wherever is appropriate, and the engagement has been fantastic. So my greatest wish is that if we can manage to keep that going in work going forward, and the way we start to turn everything back on, then I think that will be an absolute win.
Thanks very much. Tony Griffin.
Sorry, I just would like, I don't know whether you can hear me.
We can.
Thank you. I would like the dental technologists to get a little bit more airtime about what they're doing. We've submitted our questions, and I have realised what you said, Sarah, but there's an awful lot of information in there that we want answers to, please. Dental laboratories are shut down completely and are sort of on the edge, and nobody is really saying anything to them at the moment.
No, I absolutely get that, and I have every sympathy and empathy with the difficulty you're in, as many others are too, with the lockdown that is clearly not unique to dentistry. But I absolutely appreciate the issues you're doing, and of course there will be an even longer, let's face it, a longer journey back. for the work that needs to be done, valuable work that needs to be done. And I think it was Kevin Lewis last week in the FMC Dentistry that, you know, highlighted that we still do and will still need dental care as well as stabilisation, restoration of function, but restoration of aesthetics going forward. You've asked about timelines, and I've explained why we can't give timelines. You have asked a number of questions there about your laboratory and the conditions, and I've said we'll get back to PHE and IPC because they are the ones that answer the majority of those in terms of your working conditions, the safety of your staff. In terms of clinical care, again, I've laid out that there is a slow, graduated, phased approach, and I'm sure you understand the implications, not just for you, but the requirement for it, more importantly. Happy to take a number of those issues offline, but at the moment I'm focused on getting practices open as soon as is reasonably possible, safely and effectively. Once I've got the conditions and the agreement of Public Health England, CMO, and those empowered organisations that we can safely and effectively open dental practices, then clearly that has an impact on your ability to be able to step up to the crease and do the things you do so marvellously. You know, that is the way of things. You know, I cannot perhaps give you any more clarity than that at the moment, because that is where COVID leads us. And I ask you for your understanding and your patience in that, and acknowledge that you've asked a number of questions again about your working environment, and they need to go back to the IPC leads, the Public Health England leads, who actually assist in defining what is safe practice for you and your members.
Thank
Happy?
you very much for that. Thank you very much. CDTs do need some consideration as well. Thank you.
They do, and again, the one of the things that we're trying to understand is in terms of the domiciliary care that we're going to need to be providing for shielded groups, the vulnerable groups, domiciliary. And again, I'm not trying to, poor old BDJ might get their money's worth of downloads if I keep advertising my opinion article. Please don't charge anyone for it, Martin. I think you should go out free of charge if possible. The point there is I talk about domiciliary because that is going, you know, that is going to be a critical feature for many patients. I mean, if we are going to be restricting visits into care homes, that means people can't be leaving care homes. We are going to continue, I sense, with insulation around care homes, and the very delicate balance about protecting shielded and vulnerable groups that are not going to be able to perhaps enjoy the lifting of restrictions of lockdown in the same way that many of us aspire to over the summer. So I think that that's going to be a whole host of skill sets that we are going to need to revisit with the support of Health Education England. I've got Stefan. Did I see a hand raised that you wanted to come back with something else, or is that just the little icon that's not been switched off?
No, I'm fine, thank you.
Okay, so I've got. I'm just going back. Nick, you've got an icon up, hand up icon. Do you want to say something?
Yeah, I was just going to add to that piece that Tony raised about. I think the other thing that it would be certainly appropriate to do is make connections into local dental networks, because as work goes forward, I think we're going to need those clinical dental technicians and dental technicians working in those groups. So I would make an active connection into those groups. I think that will be another important piece of just adding that cog of the dental team into the areas where it needs be. So I would actively encourage you to do so.
So just building on that, one of the things that COVID has perhaps brought home to the profession is that, as I mentioned before, you know, in effect, Wales is the size of Manchester. Scotland is in effect the equivalent of the London region. We are dealing, therefore, with almost seven devolved administrations in the England footprint. And what has been extraordinary is watching the clinical leadership in each one of those, our own England, I'll use them, the devolved administrations, the east of England, and I'm sorry, Nick, you know, what's been going on there, the stuff that Simon Hearnshaw's been doing, and the Yorks and Humber. I joined the UDC network meeting for Yorks and Humber last week. What we've seen coming out of the Midlands and the partnership where where unfortunately we lost Janet as an LDN chair, where we've watched people leaning in, and the West Midlands piece with Newler Woods and the partnership between the practitioners there and the commissioners. So it is the ability for each individual region to understand what the needs of its community are, what the talents of its dental teams are in that area, and to literally own and grasp what is needed and draw on that. And that has been fantastic. That is the model of NHS England. It is 7 regions that can self-determine what is best done for their patients in those areas. And we need to make the connections, not just through the office of CDO, but you need to be urging your members to be reaching out and working with LDN chairs who work closely with the commissioners, have then got the networks out into, as Nick does, into the dental schools. I look at what Simon Hearnshaw's doing in terms of, again, the galvanising of the community water fluoridation. Please use your organisations to make the connections with each of the BDA regional representatives. And I know, for examples, down in the southeast, where there's been some close partnership working between the local BDA section, the hospital where Millie Doshi is working at East Grinstead, and the sort of the DCP leaning in there. And you know, again, I use that, the Mouth Care Matters piece. You'll be aware that we are really got our foot in the door in more ways than one in terms of the enhancing health in care homes as part of the primary care package. We are putting, I'm not, you know, I'm not going to allow us to do a session like this without saying it. We are putting the mouth back in the body, and we've been able to do it because of the strength of the community, the dental community at the regional level, picking up the baton and going forward. You know, we've seen FGDP lean in, and Ian, in the work that he's doing down in the southwest with his many hats on, the connection with the university there, that's been brought then into the national arena, where Ian is leading that FGDP group, producing the SOPs, which fully bring in the whole of the dental team. And I'm conscious that we've got the DCPs tied in. Again, Ian, thank you for making all those connections to produce that particular piece of work. So it is a team effort. And I know sometimes it doesn't always feel like that. But it has, ironically, if we're going to, I think it was John that said to me, you know, you've got to put out of a crisis, you know, we will bring good things. And I think the communication things, and one of the points that's been made in the chat box today is actually utilising the technology we've got here. It is not going to be difficult to start bringing people around the table. So using this forum, rather than asking people to come all the way to London or all the way to Leeds or all the way to Manchester, we should be putting in these forums. And I think the suggestion was that, you know, at least every 6 months. So for me, we've taken away we've done this once. Why has it taken us this long to be able to do it in this particular way? I know I have individual meetings with individual groups, but this works really well, and we can start broadening that out and making that something that we do on a regular basis. Andrea, was there anything else? I've sort of got a comment here saying that we may not have heard from you. I'm just going to give you one more opportunity.
No, I just wanted to reflect what everyone else has been saying, that I've got a lot of technicians, and I know all the rest of the technicians group have, that are a little bit upset, worried, anxious, and feeling like they're not being taken into consideration, because obviously the biggest concern at the moment is getting the clinics up and running. We completely understand that, but even if it's just for you to connect with them sometimes and say, look, we've not forgot about you, but we need to make sure we get this in place, and then we can actually help advise you as well. If they feel like they've got that connection with your office, even if it's like, say, one line in a report every now and again going, by the way, we haven't forgot you, but I think it would really, really help. And just for us to all be able to sit down and just discuss our concerns with you guys on a slightly more regular basis, and then we can then relay to our members and our technicians group, say, yes, we are having these conversations with you. We are involved. You are taking our thoughts and their concerns into account. I think would do wonders just for a little bit of morale, if nothing else at this time, you know. So that's basically just what I wanted to say. So thank you for the opportunity.
Got the message loud and clear, and we've started that thing. But you know, we are always here. I'm not asking for violins, but sort of since January the 31st, I think it's been sort of regularly significant hours in a day, I'll say that. And, you know, Saturdays and Sundays, the only difference is those are days that now begin with the letter S. There is no difference. And, you know, I know it's frustrating for many practitioners who, because of where we are, have been thinking, what can I be doing? This seems unique to me. You know, I sit here with other people running around this building. We have been conscious of all the efforts everybody's making. We're also very conscious of all the frustrations. There is no deliberate misthought. It's just sometimes there haven't been enough hours in the day. So this is an absolutely great opportunity for us to connect, but more importantly, take away the lesson identified, which you have absolutely and compellingly made, and that's absolutely registered. So thank you for that, and thank you for, dare I say it, being so patient and keeping the faith, because that, as I said, I think it was to Simon Flaherty, you know, it is keeping the faith. People still want oral health care. We have not been able to give it to them in the quantity that they want at the moment because of the risk management. But that is going to change. We will be able to come back not just with quantity, but also with quality. And, you know, that is absolutely clear. We just, as I say, we just need to get the right conditions so that we can, and I'm going to say, safely and effectively make that transition back and make sure that we get everybody doing what they love doing best, which is just doing good patient care, great outcomes. And if we can get a little bit of flexibility in the commissioning contract, that would be quite useful. But that's me being very positive about what we might be able to achieve at this. So I've just put up the last slide here. The work that came out from the BDA yesterday in terms of the representative organisations, and whilst I know there are some public or arm's length bodies that are also supportive of this, this is the team or the groups of individuals that signed up yesterday. If you would like to sign up to this particular statement, what we would aim to do is bring that all together. We will be publishing or asking you to publish on your websites with that intent to be able to explain how we are collectively as a profession looking to move the whole agenda forward, but do it, as I say, in a safe and effective way. The email has gone out, and really what we'd want you to consider with your members, if you'd like to go ahead and email back to us, we'll turn it around. The aim would be is I'd like to be optimistic and say by the end of the day, but I know that many of you may have engagement with your members that you want to speak to your leadership teams. It would be nice if we could certainly get that out no later than you know, ready for what will be Tuesday after the bank holiday. If we can get it out before the bank holiday weekend, that'd be great. I don't want anyone to feel left behind. Giving us an intent would be useful. If you feel that you don't think you want to sign up to it, then I fully appreciate that, and there is no, that we're not compelling anyone. But I just think it's a powerful message to send to the public that we are working across the whole of the dental profession, and that's the opportunity I'd like to offer you there. So I've overrun, as I always do, but it's only 6 minutes, so I think I've done quite well. I'm going to ask any last, you know, if anyone wants to, there's a little hand icon in the box. If anyone wants to put up want to be able to say any last thing, please pop your hand up in that box now. Otherwise, I will call this to a halt at 12:08.
Okay, thank you.
No, can I just say thank you, everybody. It's a difficult journey, and we're probably only at the first service station. We've still got a way to go. As I said, I'm not even really talking about the post-COVID era in terms of our next steps. Our next step is transition to recovery before we even go into restoration, and then it's the I think it was Avi Banerjee used the word PPE the other day to mean post-pandemic era, which is the sort of PPE I'm hoping we'll get to. Thank you very much for your patience, your time. I hope your ears aren't bleeding too much from me pouring words into them. We are going to get there. and your enduring support and all those little notes that I get from you. Thank you very much to every one of you. The text messages just resonate loudly against some of the other clatter and the noise. So thank you very much.
Thank you.
Thank you very much. Goodbye.
Bye.
Thank you.
Take care, everyone. Thank you very much.
Bye all.